Good evening, everyone. You are going through the program of today for the wrap-up. You have seen plenty of things. Unfortunately, we cannot watch everything. That's why we are doing this wrap-up, going through the program, telling you what was interesting, the messages to take home. I will begin with Jerry. Can you tell us what was interesting and what are the messages?
The amazing intervention session today was extraordinary. There was a mixture of all sorts of different things. Concentrated, the first two cases were on false lumen and how to deal with them in difficult aortic dissections. And we had the master, we had Hervé Rousseau from Toulouse talking about a very unusual method of dealing with an expanding false lumen, which I thought was very clever.
I saw this too, yeah.
Yeah, it was really just not something that I would have thought of, and he got a beautiful result. And then there was an endovascular snare of a stent, and I was like, oh, Lord. So it's brilliant. I mean, Amazing Interventions for me is one of the highlights of the entire meeting, because you get to see experts dealing with really tricky situations in very lateral thinking methods. So for me, that was fantastic. The other thing that I thought was really good was venous intervention in children. And when you think about venous intervention in children, you think about maybe AVMs or venous access, but actually they were talking about much more widespread stuff. So there was varicose veins in kids, what to do with them. And I do get quite a few children referred to me, and I don't know what to do with them. So that was really interesting. And then venous stents and filters in children. And again, we tend to shy away from putting stents into children, but it can, without putting in a stent, it can retard their growth and impair function, particularly, say, infrahepatic inferior vena cava. So that was very good. And it was led by two experts, Alex Barnacle from Great Ormond Street and Anne-Marie Cahill from Philadelphia. So I thought it was a really interesting session.
I think you are right. For me, it's the same. You know, I think the two extremes of intervention are amazing interventions and complications.
Yeah.
The two sessions, you learn a lot.
You learn an awful lot. And the amazing interventions, because particularly with the on-demand ability, you can pause it and you can actually ask yourself, okay, what would you do there? And you're like, I don't know what I'd do there.
I would run away.
So
I would run away.
I would send it to Hervé Rousseau is what I would do, because it was very clever what he did, you know, and it just gave, a different option. And so that next time you see that in your practice, one might think, I'll go and have a look at that. You know?
Exactly.
So
I think that's a great learning curve. That's a great learning curve.
It's good, yeah.
Thank you so much, Jerry.
Thank you.
Thank you to being with us. Okay, Fabrizio, your turn.
Yes,
what was interesting today for you?
Oh, I mean, the program is impressive and totally, but I think the management of the portal hypertension was very interesting. You know, this is a very rare procedure. Not many of our colleagues are doing, but it's the only one tips that can save life, you know, because nowadays portal hypertension is still a problem, and there are not so many centers, and there is no many alternatives for the patient. And at the end of the sessions, we learn also something regarding the BRTO. There is another option that in those patients where a shunt is not an ideal solution, this is always a great technique. A little bit difficult, but I think that we learn how to manage and when to use it.
Especially in emergency, I think when they send you the patient is bleeding and you have to do it, it's not an easy situation.
Yeah, when there is a special situation where you are not able to create the shunt, you know, you can occlude the varices and then reduce the pressure, then you have a very nice outcome for the patient.
It's not for beginners, I think, no?
No, I mean, no. It's better that you have practiced a little bit more before, you know, just in case. You know?
Yeah, that's it.
And another session was the radial access. You know, this is, I can consider a new frontier for ER, because every time we are looking to cardiologists, you know, the devil, you know, you are using the radial access. And everyone started, especially, you know, the little bit older guy, there are a lot of complications with the radial access.
Yeah.
But nowadays we're using more and more, especially for different procedures in the abdominal, branches. And I think that this session was interesting because they indicate which patient is more, you know, a good candidate, the pros, the cons, and definitely was a nice debate, you know, when to use and how to do that.
Yeah, I think that's good. That's a great access. Cardiologists are used to it, you know.
Yeah, they're using it every time, you know, and but we have also the advantage that we use ultrasound guidance because cardiologists are still, you know, blind, just feeling with their hands, that we can consider this like an old-style technique. So we can combine our, knowledge regarding the femoral access, but with the advantage of the ultrasound guidance.
I like it, the radial access, because when we are doing intervention, combined intervention, and the patient is in prone position for a kidney or something like this, you can still go with radial access without, doing the first step and turning the patient during the second step.
Yeah, but the great advantage is also for specific procedures like the prostate embolization or uterine fibroids. Patient can stand up immediately, they can walk back in
with the compression device and very quick.
And that's it. So I think this also reduces the invasivity of our procedure. So we stress more the concept of mini-invasive treatment.
Do you think we can still expand the indication of radial access?
I know there is a lot of interest also from industries because they are working on longer devices because as usual, when you work from the radial access, maybe pushability, trackability for peripheral arterial disease is not the same. But I think in the future, this could be another good option for us. So we have to keep an eye on this technique.
Thank you so much, Fabrizio. Thank you for your expertise. We are using you every night to come and comment on this. Laura, your point now.
Yes. Today, there was really no topic in the interventional oncology category, I would say. That was the actual role of radioembolization in HCC. And actually, the presenters really did a great job because they underlined the future, probably, for future research. First of all, the role of radioembolization before surgery, so radiation lobectomy. The fact that surgery after radioembolization is safe, can be done. And you prepare the patient for future liver surgery, increasing the remaining liver. You test the biology of the tumor, and this is a concept we have touched many times, and this is, again, very, very important. And in the case that the patient is not resected anyway, you will obtain with this specific dosimetry, with the high doses into the tumor, very good results even in the long term.
Yeah, absolutely.
So this is important and was followed by an interesting presentation regarding dosimetry specifically. And the approach to radioembolization has changed. We are now thinking to it more selectively with a TACE approach. And this has been very well underlined. The results are definitely different, and therefore we have learned how to perform effective TACE. And this brings to the fact that the reason why probably the randomized trials have failed is because we...
Wrong dosimetry,
Yes, we did the wrong procedure.
That was the discussion yesterday with Philip and you. That's exactly the dosimetry is the key.
Is the key for all procedures, and especially for radioembolization. So we understand this, and also it was very well underlined how much liver function is important.
Absolutely.
Therefore, we also have to select better the patient for radioembolization to preserve their liver. So concentrate the dose into the tumor and not to the liver, and select those patients that are fit for radioembolization will give us the better result.
And collaboration with nuclear medicine is key too. You need to have a collaboration which is very close, and good nuclear medicine who are interested to do this.
Yes, and physics also. So
exactly,
it's a matter of collaboration again. And finally, combination with immunotherapies. And the impression is that the target is moving a little bit, intermediate stage, early stage, advanced stage. So the final message was, please collect data and publish studies. So I think it was, a call to the army for us and also for companies to support us in such studies.
Again, you're coming back to creating and having evidence of what we do.
Yes.
Absolutely. Anything else to underline for this nice day?
Yes, there was the session IO for IO, another classical one. And the evidence, again, still needs to be increased.
Absolutely.
We know that immunotherapy alone only have good results in 15-20% of patients. And so our role is to improve the results of immunotherapy, making cold hot.
Yeah.
So different therapies with different characteristics. And the final presentation was really useful because Lambros Selikas was giving us very practical advice how to build up a practice in preclinical and clinical for designing and conducting these studies. So it was really an excellent.
Yeah, and then synchronization of the treatment. Again, I think
Yes.
that's still a question now, when to
Yes.
do it and
to make both treatment not influence the others, I do a suboptimal ablation because there is immunotherapy. No, Lambros was clear. Always pursue complete treatment.
To the maximum
Yes.
you can.
And do not interrupt immunotherapy if you're doing
Great.
ablation or treatment. So it was really, really
We are
impressive.
still learning. I think
Yes,
we
a lot.
have so much questions and we don't know. And when you discuss with oncologists, they are telling it, I don't know.
It is true, and it was useful for me also to learn about the topic. So
Great. Thank you so much, Laura.
welcome.
Now I'm turning toward Philip. Philip, you had a busy day too today. Tell us about your day.
Oh, really?
Not everything, but about the sessions more.
I would like to highlight, of course, our second and last honorary lecture.
Absolutely. Good one.
As you know, we had this honorary lecture today, and Professor Conor Tepper, that our community and our society wanted to honor
him. Absolutely.
We just learned yesterday that for private and family reasons, unfortunately,
we are missing him.
It was not. I am missing him because it's not only a colleague. We were together many years in Tübingen, and of course,
we
missed
here.
him. Yeah, we
like
wanted
yesterday, like David Breen.
Yeah,
we wanted him to be with us.
Yeah, maybe I've seen. Special thanks also to Stefan Müller-Ulsbeck.
Absolutely, he has done a great job.
He did really a great job. He wanted to make the talk for Gunnar Tepper with the work and with the slide from Gunnar Tepper.
Very difficult exercise. I told him.
It's a
thank you, Stefan.
Yeah, thank you very much for that. Yeah, and. I mean, the discussion was, of course, when you know Conor Tepper's discussion can be the drug-eluting technology and
all research he has done and the paper, the publications,
incredible. It's an incredible researcher. I mean, it's one of the reasons.
Yeah, we
wanted to honor him.
Absolutely.
But he is one of the inventors of the technology with Ulrich Speck.
A visionary, yeah.
It was a vision, it was a lot of work. We know him as an excellent clinician, and we know him as an excellent researcher. We know him as an excellent speaker and excellent writer. So perfect for the honorary lecture. And I just had a call with him, and
we are missing him anyway. You told him we are missing him.
He missed her, and we are missing him. Yeah.
Okay.
Maybe 2 or 3 words to the drug-eluting technology. So, first of all, it's not dead.
No.
It's still there.
Yeah.
There is, room for improvement still now. Yeah. After around 15, 16 years of evolution of this technology, there is new technology in how you are loading the balloon, or you are loading the stent, which patient with, it's a categorization with this technology. And there is a bright future for that. I believe. I'm not a specialist for vascular interventional radiology, but it was a fantastic talk from Gunnar and from Stefan.
I was listening to this carefully.
Yeah.
I missed other session because I wanted to listen to this.
Oh, okay. No, it was really, really excellent. More than excellent. Yeah.
Thank you, Philip. Thank you so much, Philip.
You're welcome.
We are coming to the end with me, which the session I was expecting to see was to meet the PI. I think, again, we are insisting on research and everything we are doing about research. And the PI today were impressive. Majority young people. That's, again, something essential for us. And that was great to see. I have seen many things, going from pain for embolization, prostate, and everything else. And now, I think after a busy day like this, I'm inviting you again. Stay with us, be interactive, visit the poster, and go on the platform in the industry. That's important. to be interactive and very dynamic. We count on you. CIRSE is doing his best, and you are doing your best too. I loving your sending us questions. This make us live, and it give a lot of energy to the people who are giving you the lecture. Thank you very much, and see you tomorrow.